Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. You know that moment when medicine starts to catch up with what patients have known all along? That a disease is more than the signs that show up in the exam room? Sjögren's disease is having that moment right now. We're watching the research pivot from how dry are your eyes to how and when can we quiet the immune system before the damage is done. In this podcast, we've previously discussed Sjögren's disease with Dr. Sarah McCoy, and we focused our discussions on the diagnosis, current treatment, and monitoring for patients with Sjögren's disease. In that episode, she hinted at some of the novel treatments that are coming down the pipeline. I highly recommend that listeners who are interested in Sjögren's disease listen to that episode if they haven't already, which was released in October of 2024. But today, I'm joined by Dr. Dana DiRenzo to discuss these novel therapies: BAFF blockade, CD40 ligand inhibitors, FcRn antagonists, that for the first time look poised to alter the disease course rather than just chase the symptoms of people with Sjögren's disease. We're going to dig into the science, the trials, and the big question: how early is it early enough to treat? She also shares her wisdom about managing the various symptoms of Sjögren's disease with what she calls the 4 pillars of health. Dr. Dana DiRenzo is an assistant professor of clinical medicine at the Penn Sjögren's Center. She received her undergraduate medical degree from Temple University and completed residency at the University of Maryland. She then went on to complete a fellowship in rheumatology at Johns Hopkins Hospital, as well as a Master's of Health Science. Her research interests in Sjögren's include health-related quality of life, and she's on the steering committee for the Outcome Measures in Rheumatology, or OMERACT, for the Sjögren's Working Group. So, settle in. This is a conversation about the future of Sjögren's care and about what it means more broadly when an autoimmune disease finally gets the therapeutic interventions it deserves. Dana, welcome to the show.
Thanks for having me.
Super excited to talk about treatments for Sjögren's syndrome. I know Sjögren's is something that you've worked on pretty much for your career. Was
That's
hoping
correct.
to give us an introduction of, what is your understanding of Sjögren's and how does it cause the various symptoms that it produces?
Right. So the more that I do Sjögren's, the more that I've realized it is incredibly complex. So Sjögren's is a multifaceted, complex autoimmune disease that can really cause a multitude of symptoms, especially if you're on the lookout for it. So if we traditionally think of Sjögren's as a dryness syndrome, or could hallmark just be dryness and we're just going to worry about that, we're going to miss a lot of things and aspects of the disease that can really be impactful to patients. So when we think about Sjögren's, I interact with fellows a lot and they join me in clinic. And what I tell them first and foremost is get in the mindset that Sjögren's is an immunologically based disease disorder. So start thinking about the immunology of things. Don't think about it as, and start going down my list of how dry are your eyes, how dry are your mouth, because you're gonna miss the boat from the get-go. So get into the mindset. What's the pathophysiology and what are all the different ways that the immune system, especially a very ramped up immune system, can affect you? So when we think about that, at a basic level, what's going on? So this is a autoimmune, primarily B-cell mediated disease, although a lot of interaction with T cells as well. We think about the hallmark antibodies being Rho and LAW, mostly Rho, and they bind to these apoptotic cell fragments, these debris in glandular tissue, and then it causes this complex cytokine interaction and these damaging events that could lead to glandular dysfunction or loss of function. So the one thing that is so important about that is when you're at the point that the damage from your immune system has caused loss of function, you're a little bit behind. You're missing a huge window of opportunity. So the other thing that I say to fellows when they come and start presumpting me with clinic is, like they didn't have dryness. And I say, I don't care. What are the other things that they're telling you about? Are there any B-like or B-type symptoms, constitutional fevers or general malaise or fatigue, swollen lymph nodes, subtle rashes? They're just not feeling themselves. Are they feeling flu-like? It's because you want to look for evidence that your immune system's getting really ramped up. And then, of course, you're checking their labs for certain features and especially antibodies. But at the point that you're really noticing a lot of dryness, that process is moving. That process is cooking. So when you ask me, what's my understanding? I don't know. Everyone is trying to understand Sjögren's. I don't know myself, but I do know that it is just not a dryness syndrome. And if we think of it like that, we're going to lose a lot of important features.
Super, super interesting and important to make that distinction and realize that. So up to now, how have you managed these patients with Sjögren's syndrome? As you mentioned, it's not just about the dryness. They may experience other systemic symptoms and have other features of the disease. So what tools have you used to help improve your patients' lives up to now?
Right. So there's a lot of aspects that we could be managing and treating. Usually you can't tackle it in one appointment. So I usually start with the patient and I say, what is the most bothersome symptom or aspect to you today? And we're going to tackle
fatigue.
Yeah, fatigue. Right. Actually, well, if you want to start with fatigue.
Let's do that.
All right, let's start with fatigue. So I'll go into my fatigue spiel. So fatigue is sometimes a reflection or can be a reflection, again, of what we're talking about, this super duper ramped up immune system, which is a very energy consumptive process. So it takes a lot of energy away from your activity levels if your body's churning out all these extra cells, these inflammatory cells, these cytokines are soaring about your periphery, et cetera, et cetera. So it takes a lot of energy to be inflamed. So when we think about how do you tone that down, so I say, give me the homework of trying to tone down your immune system, and I'm going to give you homework to try to tune down your basically sympathetic drive. So one of the things that we think about in Sjögren's in particular, but is really present in a lot of inflammatory autoimmune diseases, is autonomic dysfunction, a really ramped up sympathetic drive compared to the ratio of parasympathetic drive. And why is that important? That also is very energy consumptive. So if you're in this constant low grade to high grade, maybe fight or flight response, you're also going to feel really wiped out. So I go into essentially what I call the 4 pillars of health, or I say we need to talk about your base, your chair, or the 4 pillars of health, meaning 4 legs to the chair. So that would be diet, exercise, sleep, and mental health. And it's this long-winded explanation to go into why that's important for tuning up fatigue, because these all can offset or contribute to the imbalance between sympathetic, parasympathetic drive and ratio. So I'll go into sleep, like, how's your sleep? And they say it's been poor. We do know, based on a lot of data, that patients with poor sleep also have higher sympathetic output and drive, which, is not helping fatigue by any means. And then diet, there are anti-inflammatory diets and diets that we know can be associated with increased energy. Mental health.
What are those diets? People ask about diets all the time.
So there's a lot of good ones.
Is it all about the Mediterranean diet?
I am all about the Mediterranean diet.
Yeah.
I am all about the Mediterranean diet, which is high in omega-3s, omega-6s. And we know based on a lot of good data that is anti-inflammatory. And then foods high in antioxidants can also boost energy. There's also a fine balance between the amount of caffeine that you can consume, because then that might lead to other issues. But for a patient who's really fatigued, Sjögren's in particular, sometimes that could be helpful. And then the other one is mental health. We neglect to focus and talk about this a lot in rheumatology, general medicine in particular. But if you're having a lot of health-related anxiety, depression, that's also contributing or pulling away from your energy store. So it takes a lot of energy also to be anxious. So I start to tell people over many appointments, let's now talk about your mental health. What are you doing? Can you engage in mindfulness, meditation? Are there other stress reduction classes you like? Yoga, Tai Chi, etc. There's a lot of various things that they could be doing that could be helpful for that. So kind of just to reiterate, 4 pillars of health: diet, exercise, sleep, mental health, and then tuning down your immune system, which is pharmacology, which is a little bit limited currently, but hopefully more on the horizon. So fatigue is complex. It's not just one thing, but if it were one thing, then whoever understands and figures that out is going to win the Nobel Prize.
I like that. Yeah. So fatigue, a very, very common complaint, not just in patients with Sjögren syndrome, but in patients with a lot of other rheumatic diseases. And I really like the way that you sort of structured the 4 pillars of health and how each can contribute to fatigue or make it better. The other thing that people complain about is dryness. Even though it may not be the symptom for everybody, a lot of people have dry eyes, dry mouth. What's your approach for managing that?
All right. So if we start with dryness, which is also pretty complicated, and what we're trying to understand the ratio to, if you will, in terms of Sjögren's care and management is when is dryness a reflection of an active process and when is dryness a reflection of damage or chronicity? And I think more and more, and as more drugs are in development and coming and becoming available to us, it'll be when and how early in this process can we treat to prevent damage. So again, if we packed up to that previous mention of the pathophys, at the point that you're having glandular destruction and loss of function, it's a little bit too late. But if we talk at the most basic level of just symptom management of dryness, for eyes in particular, there's a lot of great drops, both over-the-counter lubricating drops, but then a lot of immune modulating and suppressive drops that you're adding directly to the eye, like Restasis, the cyclosporine, prime example of that. So there's a lot of great ways that you could help a localized dry eye inflamed environment that is not necessarily giving you systemic immunosuppression. But when we think about dry eye management currently today, there's a lot of options that are immunosuppressive. It's just topical. And then in terms of mouth, that is, I would say, a very, very frustrating aspect for patients. There's really only 2 different sialagogues on the market to stimulate saliva, very similar mechanism. They could come with some side effects, jitteriness, excessive sweating, sometimes drooling, which is actually a good thing. So if you're at the point where you're drooling from one of these medications, it means that you have some preserved gland function. But there's not really a lot of medication management out there. And then certainly there's a ton of different over-the-counter products. The other 2 things that I would want to mention in terms of your dry eye care and dry mouth care would be engaging with ophthalmology and finding, hopefully, not only an ophthalmologist, but an ophthalmologist specialized in dry eye disease. So there are, just like everything in life, a lot of complicating factors of dry eye disease that I think we really underappreciate when we're working up the patient. So I see a lot of referrals for Sjögren's. Dry eye automatically just gets a rheumatology referral, when really dry eye should automatically get an ophthalmology referral to think about the XYZ things that are coming into play. Allergies, meibomian gland dysfunction, a lot of screen time. If there was previous eye surgery like LASIK, there's a lot of different things that are coming into play with that. Other medications, we think of that only for dry mouth, but a lot of times medications could sometimes affect the eye as well. And then likewise, engaging oral medicine. So making sure that the patient is partnered with a great dentist or oral health provider, oral medicine, that could give you differentials for dry mouth. So could the person have a localized dermatitis or lichenoid process going on in their mouth? What are the medications they're on that could also contribute to dryness? Do they have some type of indolent infection? How's their dentistry? So there's all these factors that are coming into play. So I usually spend the first appointment or 2 with patients talking about all the many things that we need to look into and tune up and maybe exclude before we could even get going on the immune system itself. So you really have to have partners if you're going to be caring for Sjögren's patients properly in ophthalmology and oral medicine.
I love it. So we talked about the management of the sort of traditional cardinal symptoms of dry mouth, the importance of working with an ophthalmologist that is knowledgeable about dry eye disease and a dentist that can also help rule out other contributing factors. We talked about the 4 pillars of health that is important for addressing fatigue. Any other sort of tools or things that you commonly use currently to manage patients with Sjögren's?
No, I mean, that's a lot of things.
Yeah. Yeah,
um,
that takes several appointments like you
yeah, it
mentioned.
really it takes several appointments. Now, as we get into kind of subtypes or different aspects of disease that not necessarily everyone is going to have, like neuropathies, for example, you could be partnering with neurology, but also dedicated physical therapy and stuff like that for chronic pain aspects. So then that's going to get into specialized care. But for the general patient, I usually like to just say from the get-go that you're going to have a multidisciplinary care team. It can't just be one person, the rheumatologist, because I would be remiss in your care if I didn't fully understand your dry eye or fully understand your dry mouth.
Love it. So today, are there currently any sort of disease modifying agents like we often talk about in rheumatoid arthritis, right? In rheumatoid arthritis, we put patients on methotrexate, on biologics, and we can get them into remission. We think that those medicines sort of prevent progression of disease. Are there any such treatments for Sjögren's currently available?
Currently not. So, very unfortunately, there are no FDA approved medications for Sjögren's disease specifically. So that doesn't mean
Hmm.
that a patient might be without immune modulating or suppressive care, but we're borrowing from other diseases, which sometimes gets to be very tricky for insurance coverage. And then tricky because it might not be very heavy mechanism based for Sjogren's specifically. So no current FDA approved medications, but there are some that we commonly use. So that would be like the hydroxychloroquine. We could use that for mild arthritis. We could use it for rash. We could use it for mild gland swelling. It unfortunately doesn't improve dryness per se itself. So patients commonly come in and they're like, what about this hydroxychloroquine that I read online? Oh, and then they come back in and they're like, it's done nothing for my dryness. And I say, yeah, I don't think it was going to. So there's been a couple studies out there, actually many studies, looking at does this improve dryness? Unfortunately, it does not. It's immune modulatory. Then there's the traditional agents that we all kind of think about, methotrexate. If someone has a lot of inflammatory arthritis, you could use azathioprine for more of a glandular-based phenotype, or if someone's having a lot of serositis, cyclophosphamide, of course, if it's very, very severe vasculitic features. And then, of course, rituximab, if someone is having a lot of glandular swelling, high-grade inflammatory changes, those B-type symptoms that we're talking about, with evidence of very high levels of inflammation, immunoglobulins, maybe cryoglobulins, etc. So there are some agents that we lean on and go to, but there's not a specific FDA-approved Sjögren's medication.
I think over the past, 2 to 3 years, there's been several published journal articles commenting on these new medications that are sort of in the pipelines with new mechanism of actions, which is what, we want to focus the rest of our discussion on.
Sure.
Which one do you want to talk about first? Which one excites you?
So there's a couple very exciting ones. I guess first on the list would probably be ianalumab, which is a BAFF blockade mechanism. So it's looking to interact with B cells, and then it is crucial for B cell survival and maturation. So if you block that signal, then you're going to lead to decreased B cell activation. So this one is promising in the sense that they have good data to show that it decreases the SDI. The SDI is the most commonly used metric for disease activity in Sjögren's. It's a 12-point or 12 domain scoring system, and it's shown response in that. Word is still out whether or not it had significant improvement on symptoms. There was trend, but not significance on their data there, and they'll be releasing more data when they're able to. There's a little bit of disconnect, but more data to come, and I would be exciting about that. It also had a very good, oh, sorry, go ahead.
No, so you're saying if it doesn't affect symptoms, what does it affect? What is it efficacious for? Is it for the lab findings?
So it's a composite. So the SDI is
Mhm.
a composite outcome. So it was shown to improve on lab findings and showed actually some response in salivary flow rates too. So
Mm.
their responder index, which is greater than 3-point SDI drop, showed improvement there. But in terms of what patient reported symptoms based on the S-free, which is also a confluence of 3 different aspects. So pain, fatigue, and dryness from 0 to 10. So a VAS scoring scale. It did not have significance there, but trend.
Interesting. How do you reconcile that?
I think it's really tricky because I think that these certain patient-reported symptoms are really complex. So we just talked about all the various things that need to come together to maybe improve fatigue. So I think it is really a hard judgment on any drug to look to see if it improves certain features like that. And I think some of these, based on how long the half-life is and how many times you have to get it, et cetera, et cetera. So looking at, and we all judge things at set amounts of time, 3 months, 6 months, 12 months, et cetera. Sometimes maybe patients need to be on drugs for a period of time to show real symptom benefit. So I think it's tricky. And I think that's a tricky set of outcome measures to kind of put as a primary outcome. What I think we're looking towards as a Sjögren's research community would be patient-reported outcomes that are looking more at interference. So instead of looking at intensity, like 0 to 10, rate your dryness 0 to 10, rate your pain 0 to 10, your fatigue 0 to 10, how are these symptoms interfering with your day-to-day, which might be more meaningful to patients, and we might be able to better see change.
Super interesting. And do you know how ianalumab, or does it differ from belimumab, right? Which is another sort of BAFF agent that's now already FDA approved for lupus.
Yeah, that would be the mechanism of how it's being blocked. So yes, it does differ. Obviously, I can't pull off the lupus data off the top of my head, but in terms of slight mechanism differences and action of the blockade itself, yes, it does.
Super interesting. All right, let's talk about another one that I can't pronounce.
Yeah.
The CD40 ligand blockade. Maybe you'll do a better job at pronouncing that.
People in the Sjögren's community have been calling this DAS because no one could quite pronounce it, but dazodalimab.
Dazodalimab. Okay, I like that.
So it interferes with B T cell interaction and co-stimulation. By doing so, it's going to decrease signaling to the B cell pathways, and would be the mechanism of action. This drug had also very significant or hopeful findings. It also decreased the SDI in their clinical trials, and it did also have some improvement in the FcRn as well. So gains in improvement in dryness, fatigue, and pain. Response rates as well. And it was also well tolerated, I should say, for ianalumab too. One of the things that we're also looking for as a community is the drug's going to be safe. So have we seen any poor signal in terms of adverse event, especially with longer half-lives and how long the drug is going to be in circulation? So we have to really consider those things as well. So this also showed promise in terms of the SDI and FcRn.
Both of these mechanisms are similar. One blocking sort of B cell action, the other one is sort of BT cell interactions. How about other methods of trying to squash down the inflammation and autoimmune components of Sjögren's syndrome?
Yes. So there's another big mechanism of action, and there's a couple of different companies who are conducting clinical trials right now. This actually received FDA fast track for promising drug mechanism, and that would be FcRn receptor blockade. So that is going to decrease IgG or antibody levels. So this is taking a step further from B cell itself to now, antibody binding and depletion. So that has also shown very significant promise. They have shown improvement in SDI scores as well. More data needs to come out in terms of how much it's improving patient-reported symptoms, but we're hoping to see some of that data shortly. All of these drugs that are about to come to market are roughly all kind of in the same timeline, somewhere between phase 2, phase 3. So we could not be more excited of who's going to make it to the finish line first.
These FcRn receptors sort of remind me like a poor man's like plasmapheresis, right? Where you like try to like remove pathogenic antibodies, and we do that, with very intense like plasmapheresis. Sometimes we think about like IVIG of like overwhelming all of those
That's exactly
immunoglobulins.
what it's like.
It's so cool. When I read about this, it's like, wow, I never even thought that was possible. It just, give a medicine that takes out your immunoglobulins.
Yeah, it makes
That's
total
pretty cool.
sense. And it's actually something that you can very tangibly measure. So one of the things that we like to check on in clinic in terms of disease activity is your immunoglobulin levels. So what are your IGs doing? And they track really, really well with flare and disease burden. So if you have this patient who continues to have these very high immunoglobulin levels, this is something that you would potentially be thinking in terms of how do I decrease those levels? Now, more to come, more data needed. Does that then tether to symptoms and all the other facets? But this is a really cool kind of design and mechanism in terms of how we could be getting at the primary process.
Yeah, and I can envision that, these medications may also be tried for other autoimmune and rheumatic diseases.
And they are
Other,
myasthenia gravis. Yep.
ah,
Yep. But also being explored
makes a
in,
lot
in
of
others,
sense.
myositis, a lot of other different autoimmune diseases. Correct. Yep.
Makes a lot of sense. Great. Dana, any other mechanisms of actions you want to talk about?
There is also, well, there's actually a couple of them. We have the JAK inhibitors. So they're being
Yeah.
explored too. There's some background pathophys in terms of Sjögren's for the JAK-STAT signaling pathways. So more data is needed in terms of that. And then tyrosine kinase inhibitors as well, which also has promising data in terms of decreasing SDI. And like all of these, we have to see how much patient reported outcome symptom burden is improved with use of the drugs.
That's awesome. So, with all of these new medications in the pipeline, how do you think the treatment for patients with Sjögren's disease is going to change sort of in the future once all these medications become available?
I think it's going to significantly change for the better. I cannot be more excited. And then as the person in clinic talking to patients now, I'm telling them, sit tight for the next, hopefully year or two, hopefully not 3, 4, but sit tight because I think there's going to be a lot of great options. So I think big questions in the future are going to be just how early do we need to be treating? Are we going to sit on someone with Sjögren's for 10 years, if not longer? Because I'm sure many of us have patients with Sjögren's who have had disease duration that long and have not received a single drug. They might not have high mortality. It's not your patient with lupus nephritis that you're admitting to the hospital, but this low-grade chronic inflammation. But there are some patients who are extremely sick with Sjögren's, not to discount that, but to come back to, we're sitting on low-grade chronic inflammation, glandular destruction that could then go on to morph into all these terrible things, lymphoma included. At what point in terms of this pathway are we going to be using these drugs? So all these different mechanisms, and there's 3 very different mechanisms, all getting at the root cause of the problem, the B cell and the antibody formation. We're going to have options. And I think what's going to play out is other disease features and safety signal in terms of what is going to be right for each patient. So some mentions of safety signal with liver. So someone has fatty liver disease or is on other medications that might be heavily using liver for metabolism. Maybe that might be the right drug and we might reach for another drug. Maybe someone has an infection or chronic infection history that we might want to use a shorter drug of action. So with this all said, I cannot be more excited that there's going to just merely be options to give patients and to not feel hopeless in clinic. I don't have something to break the cycle. I don't want to be the observer. I don't want to be the patient who comes in and say, all right, let's check your immunoglobulins again in a year. Tell me more about your symptoms, because that just feels terrible. You want to be treating. And I think there's a lot of nidus to be treating. So I could not be more thrilled that we're on the verge of that.
That is super exciting. And I totally agree with you. In Sjögren's syndrome, I often feel, as you mentioned, like a bystander. We could certainly help improve people's lives, but we have relatively little to offer as compared to people with rheumatoid arthritis or other conditions where we sort of get at the root cause of the problems, shut down the inflammation, shut down the autoimmune response. And here it's so exciting to hear about all these novel therapies that are now finally planning to do that for patients with Sjögren's.
Yes, absolutely.
What questions remain? What are the unanswered questions that keep you awake at night?
I think, again, going back to the unanswered question in my mind will be the patient that's not obvious, the patient without dryness, the patient who actually might not be labeled as Sjögren's at this point. So I think not only do we have to rethink our primary outcome measures and endpoints and clinical trials, but maybe we need to think about the phenotypes that we're also missing through this process. So what about patients who just have SS just, who have SSA antibodies, might even have high inflammatory markers, but don't necessarily have that really poor function in terms of salivary flow or tears? So are we missing them? And is actually that the patient we need to be capitalizing on? So yes, could not be happier that Sjögren's, defined by classification criteria, is going to have these FDA-approved medications. But my next big question is, how do we define the patient before then? Like, how do we define the patient that I don't want to meet classification criteria? Like, I don't want them to have a salivary flow of 0.1 mils per minute, because at that point, that is far beyond,
Too late.
comfort for anyone. So I want to
Yeah.
focus on the person before the Sjögren's diagnosis.
I love it. Dana, this has been a really awesome and exciting conversation, and I can't wait to hear more about getting these medications out in practice and seeing how they impact your patients' lives. I hear you about how can we make earlier diagnoses in patients with Sjögren's and other rheumatic diseases so that we actually prevent them from developing all of the classification features for the disease. Dana, we'll have to have you back here once you've gotten your hands dirty in prescribing all these medications, and you
Absolutely.
can report
I
back
would love
about
to.
how they've been doing. Thank you so much for your time.
It was an absolute pleasure. Thank you so much.
What really sticks with me from this conversation is the shift in mindset. Sjögren's isn't simply about battling dryness. It's about intercepting an immune system that's cooking, as Dr. DiRenzo puts it, long before the glands are gone. With BAFF inhibitors, CD40 ligand blockers, FcRn antagonists, and more on the near horizon, that interception finally feels possible. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep those 4 pillars sturdy: diet, exercise, sleep, and mental health. And of course, stay healthy.